Welcome to our next session on dialysis. And to begin our first topic of discussion, we have with us our warrior, Merlin, to please moderate the session.
Hello. Hello everyone. I welcome you all to this session. This session is going to be about managing phosphorus to reduce pruritus and bone damage in kidney disease and dialysis patients. The management of phosphorus in dialysis patient is not often as strictly managed as potassium and other important parameters. And long-term dialysis patients almost always face some serious repercussions because of this. Through this session, we will gain some insights from our doctors about what bone damage, pruritus, and what role does diet play in all this. Greetings from Kidney Warrior Foundation doctors. It is a privilege to have you as our speakers in our annual virtual conference. Dr. Girish NS is a consultant nephrologist and transplant physician working in Manipal Hospital, Hebel, Bangalore. He worked and trained in UK for 11 years. His area of interest is swap kidney transplant. And also, I would like to welcome Dr. Swati. Dr. Swati is a senior consultant dietitian, having over 20 years of experience working with Manipal, Malaya, Colombian Asia, and Davita. She is presently consulting online. She was a member faculty at Davita Academy, also a life member of IDEAL. And she collaborated with our very own Kidney Warrior Foundation and co-authored 2 books on renal nutrition, and is also has an educational series for renal nutrition on YouTube. So hearty welcome, and over to you, Dr. Girish.
Thank you. First of all, at the outset, I would like to thank Marianne Kidney Warrior Foundation for this opportunity to present this topic. And good evening, everybody. And thanks, Merlin, for the introduction. So without further delays, I will start off my talk. And I hope I'm audible and my screen is visible.
Yes, Doctor. Yes.
So the topic I've been asked to discuss is managing phosphorus to reduce pruritus and bone damage. I have slightly extrapolated this topic not only for dialysis patients but also CKD patients. I'll start off with a brief introduction and then answer these 3 questions that have been asked to me. The first question is how early should we start the just excuse me, I'll just minimize this. Yeah. So how early should we start dialoguing with our patients to prevent the bone damage? The second question is why is phosphorus management not seriously advised? And the third question is why is phosphate binders limited in administration? So to start off with introduction, it is important for us to understand that most of the phosphorus that we have in the body is stored in the bone or teeth, almost 85%. And phosphorus balance and tissue distribution is shown in this graph. As you can see, only about 14% of the phosphorus is intracellular, and a very small portion is extracellular, which we measure. And out of that, 70% are organic phospholipids and 30% is the circulating phosphorus. So it is important to understand the magnitude of the problem, which is in medical terms, the prevalence of high phosphate levels in CKD patients. And this slide shows you what is the percentage of prevalence of hyperphosphatemia at various levels of chronic kidney disease. We can see that it's actually very less in CKD1 and CKD2. That is when the kidney function is working more than 60%. When an individual has chronic kidney disease stage 3, we see that about 10% of our patients falling in this category have high phosphate. And as the stages progress by, you can see that the incidence or prevalence of hyperphosphatemia goes higher up. And almost more than 60% of our chronic kidney disease patients have high phosphate levels. Please mind that this data is mainly from the West, So I emphasize this point because our population has a slightly lesser prevalence of hyperphosphatemia because of our diet being poor in phosphate, unlike the Western diet. So typically, the phosphorus or phosphate can be used interchanged. It can be it's the same terminology. So phosphate homeostasis depends on three organs. One is the parathyroid glands, which are small glands located behind the thyroid in the neck, and then your kidneys, and then the bowels. So and the bones. So between these four organs, the phosphate homeostasis has a complex interplay. And the root cause of high phosphorus in chronic kidney disease patient is hypocalcemia, and low calcium and inability to excrete phosphate is one of the main reasons why phosphate levels shoots up. And it's quite often it results in low vitamin D, low calcium, and high parathyroid hormone levels. So, what are the potential implications of high phosphate in the blood? Most of our patients will be asymptomatic, and it's only until later stages or very high phosphate levels, when the levels shoot up to more than 5.5, that is when we start experiencing symptoms. And pruritus is one of the symptoms. Pruritus meaning itching. And secondly, they develop mineral bone disease, which exposes them for risk of fractures. And then the blood vessels get calcified, meaning to say um, our tubes or the arteries that supply blood to vital organs, they get calcified and chalky. So as a result of which, the blood supply to these vital organs, mainly the heart, gets affected, resulting in increased morbidity and mortality. So the heart is under attack, and there is risk of um, myocardial infarctions and heart attacks. And also, it has been shown that patients with high phosphate levels, which are uncontrolled, can lead on to progression of chronic kidney disease. So the evidence behind that is this one of those epidemiological studies, Framingham offspring study, with over 3,000 participants. As you can see, the hazard ratio for those who have high phosphate levels for developing a cardiovascular event is far, far higher than somebody with low phosphate levels. And again, to address the impact of phosphorus on mineral bone metabolism and its treatment, this study was performed, Cosmos study, published in NDT in 2015. It's a 3-year multi-centered study with more than 6,000 participants, where it showed that if you treat high phosphate, you will see an improvement in your bone health. So to answer the first question, how early to start the dialogue with the patients to prevent bone damage? I think it is reasonable when somebody is in CKD stage 3. Stage 3 typically includes when the kidney is working anywhere between 30 to 60%. And that is the stage when you start educating the patient about phosphorus and its measurements and management. So the second question is, why is phosphorus management not seriously advised? There are several reasons for this. I think one of the most important reasons is patients are asymptomatic in the early phases, and they already have so many problems by the time they develop chronic kidney disease. Like they might have diabetes, hypertension, heart disease. So the pill burden is going to be quite a lot. So that is one of the reasons. And secondly, the cost implications. Adding another um, uh, pill to the existing list of medications not only adds the pill burden, but also it can financially have implications. And one of the few reasons why, as a nephrologist, I don't push for phosphorus management in certain cases is uh, I'm worried about the risk of malnutrition, especially in vegetarian patients. The moment you start restricting dairy products, then the not only are we depleting them of phosphorus, but also we are exposing them to a bigger problem, which is malnourishment in India. So typical management of phosphorus involves 3 Ds. It's a simple way to remember. The first is diet, second is drugs, and third is patients who are on dialysis, optimizing dialysis. So dietary interventions like low phosphate diet, I will go through in the subsequent slides, and appropriate use of phosphate binders and vitamin D analogs, along with, in certain cases, calcium mimetics can help. And optimizing dialysis, once you consult in conjunction with your nephrologist, is very vital in patients on dialysis, because sometimes diet and dialysis per se can give you that optimal phosphate control, and you can get away with minimal or no usage of drugs. So this is the phosphorus pyramid. This is a very very nice pictorial representation of what foods contain phosphorus, and these are distributed on
Doctor,
sort of,
sorry to interrupt.
yeah,
Yeah. Okay, your camera is working fine now. It's okay.
yeah,
Please
sorry,
continue.
yeah, apologies for the
Hmm.
interruption.
Yeah.
So yeah, so these pyramid has basically 6 levels, and you can see that the basis of this pyramid is phosphorus content, phosphorus to protein ratio, and phosphorus bioavailability. And each level has a color edge from green to red and through yellow and to orange. So the one at the top of the pyramid are high phosphorus foods containing high phosphorus uh, uh, as an ingredient, and then these green ones are those with lesser phosphate. Mainly you can see that it's the beverages and the foods or the additives nowadays that we are using which have traditionally high phosphate levels. So it's worth knowing about what are the hidden sources of phosphates. As I mentioned in that food pyramid, it is food additives or preservatives, and it's also noticed that there is poor labeling of phosphate content for some of the foods, which can basically have a impact on high phosphate levels. And interestingly, there are drugs which can increase your phosphate levels, like your blood pressure pills, like the lisinopril, amlodipine, your diabetic medicines like the sitagliptins, and antidepressants like paroxetine. And three main issues that we have to consider is the phosphorus content, the bioavailability, and the protein phosphorus ratio. You can see that certain plant products have lesser bioavailability of phosphorus, whereas certain inorganic additives can have bioavailability of 90 to 100%, meaning to say you are more likely to absorb phosphorus from these additives than from plant products. So dietary interventions classically has 4 strategies: restricting the phosphorus-rich foods, preferring plant-based phosphorus because the bioavailability is less, and when you boil, it often results in loss of phosphorus, and avoid additives. So the third question is, why are phosphate binders limited in administration? Again, as I previously mentioned in my slides, that most of our patients are asymptomatic until later stages, and they already have an enormous pill burden, which can result in non-compliance and also have significant cost implications. And also, what I have noticed, having worked in the West and in India, is that the prevalence of hyperphosphatemia in early stages of CKD is fairly less because of our low phosphate diet, which results in normal phosphate levels up until almost CKD stage 5. Uh, and also, some of our patients have significant GI intolerance to these phosphate binders. So, and we have only 2 types of phosphate binders at the moment available in India. Unlike the West, we have at least 4 to 5 different types of phosphate binders. So the limited options also gives us that doesn't give us that flexibility, and sometimes even improper administration. I give this example because the calcium supplements can be used, certain calcium supplements can be used as phosphate binders, and most of us don't know this. And this is one of the cheapest phosphate binder, but it is often administered in a very improper way. Twice a day or once a day calcium supplements are not enough in itself to act as phosphate binders. It has to be taken almost in line of 6 tablets a day. So 2 in the morning, 2 after, and 2 evening with meals. Calcium supplements act as phosphate binders. Okay, and so these are the phosphate binders that are available here. As you can see, just a couple, 2 or 3 in India, whereas there are a lot more phosphate binders in the other parts of the world. So hopefully we will have more access to the phosphate binders. Aluminium binders are some things which we don't use because they have significant impact on bones and nerves. So this is an Indian study which shows the incidence of malnutrition in our population. You can see that even in patients who are upper middle income group, there is almost 68% malnutrition, and in lower income group, it can go as high as 93%. So with this, I think we have to carefully balance our diet because we are already poor in protein and phosphorus. So then the question is, if you restrict diet, what are we, going to eat? So it has to be, balanced very carefully. So with this, I would like to thank you, and I'll be happy to take any questions.
Thank you, Dr. Girish. I mean, we know that we had some time constraints, but it was a wonderful session. I'm sure all the patients will get to know so much from this session. We will move the questions towards the end for both of the doctors. So now I move to Dr. Swati. Welcome, Dr. Swati. And this is a question and answer kind of a presentation. So let me put forward some questions that were asked by our warriors, as we call them, our members, patients, dialysis patients, chronic kidney disease patients from our group. So first question which came forward was that as a dialysis patient who produces no urine or just 800 to 1 liter of fluid, and their phosphorus is within limits. So what should that patient eat, drink more or less of to avoid this dry, itchy skin? Doctor, can you please unmute yourself?
Thank you, Merlin. Good evening, everybody. That was a lovely presentation, Dr. Girish. Glad to be a part of this question and answer round to kind of probably put a lot of queries into an answer mode post this session for the understanding of phosphorus from diet and so on and so forth. So as you said, Merlin, it's not very common that we see itching in patients if their phosphorus is in control. There is one reason that this could be, it's possibly because of excessive dryness. So one would have to make sure they are moisturizing themselves with a kind of moisturizer which will keep their moisture intact for longer hours. They may need more frequent moisturization because unfortunately there is always a cap on the fluid amount. Since they are on dialysis and also have a renal illness, it's always a difficulty for us to say, have more fluid, therefore your skin will be more moisturized. So having said that, of course, we should always be taking a dietary recall to see if actually speaking their intake of phosphorus is, within a balanced amount. If their diet in general is balanced, are they getting enough vitamins and minerals from their food? All of this has to be taken a look at before just saying that the skin has to be moisturized. I'm sure the nephrologists will also have to have their say in these kind of scenarios where there is a normal phosphorus level, yet the patient is complaining of itching. I, for one, can point out that this could be a lack of moisturizers, but I'm sure the nephrologists will have their take on this too.
Okay. Thanks, Dr. Swati, for answering that. Moving on to the next question is the role of processed, oily, sugary foods in causing bone damage over time. Will eliminating these kind of foods help in slowing down this process of bone damage?
Yes, definitely, because what is commonly known is that when you have an overdose of sugars, or if your saturated fat intake is very high, then we see that there is an increased excretion of calcium and there's a decreased absorption in the intestines. Therefore, both ways it causes that the bones to become weak because there's not enough calcium being available for absorption and for bone formation. Having said that, we can't eliminate sugars and fats from a person's diet, because for the other nutrients to do their role, like if protein has to do its role, if carbohydrates have to give energy, we must have these sources in small amounts wherever possible. The choice of fat and the choice of sugar is what needs more emphasis than for me to outright say just remove it from the diet, because as we already know, renal diets are by far the most restrictive diets. So just to say put a blanket rule and say no, don't have sugars and don't have oils is being very wrong. Professionally, they will need to sit with a renal dietitian where she takes a dietary recall, assesses the intake to see if actually the person is taking over and above the allowance, or can it be modified? Can the kind of fats be modified? If somebody is only having saturated fats, then we can explain to them that, already being on dialysis, your body is in a state of inflammation. So you can't keep taking more and more saturated fats, which will again increase inflammation. So we will tell them to look at better fats, like vitamin E sources, which will kind of combat inflammation. Give them foods which are anti-inflammatory, like capsicums are very good for that, to reduce inflammation in the system. So we'll look at the diet in general, as a whole, and then arrive at something that they are able to follow, keeping in mind that both sugars and oils in excess are not good for them.
Okay. Thanks for that again, Dr. Swati. So moving to the last question is, what dietary changes should a dialysis patient or a CKD patient focus on if they have already been detected with bone damage? So,
I'd like to say that a dietary improvement will reverse it, but unfortunately, that is not the case. When it comes to phosphorus or with any kind of restriction in a renal diet, one saying goes very true: a stitch in time saves 9. Because by the time the patient is showing obvious symptoms of bone damage, it means he has lost calcium and he has gained clogged arteries. Unfortunately, phosphorus tends to, remain in the arteries and the muscles, and it causes, as the nephrologist just now, Dr. Girish mentioned, that it remains in the muscles and everything. It causes a lot more damage apart from the bone damage in itself. So by the time the person is complaining of, being in osteoporosis, unfortunately, the imbalance of calcium and vitamin D has gone beyond repair at the first level. What one has to then do is make sure that their diet is balanced such that they don't lose calcium further. Like your previous question said, that increased intake of sugars and fats in uncontrolled amounts and the wrong kind of fats will increase the excretion of calcium. So one has to be mindful there. Again, look at the sources which are low in phosphorus. There was a beautiful pyramid that was showed by Dr. Girish. So look at those options. Try to discuss it with your renal dietitian. Tell her where and when you're finding a limitation, so we can give them healthy swaps. Like, for example, where we do need patients to have protein, but unfortunately, all the 3 P's are together. It's protein, phosphorus, and potassium. Any food that's high in protein is equally high in potassium and in phosphorus. So we'll have to look at a food that is giving them a lot of pluses. And even if there is a small minus, if we can neutralize it by giving a allowance for that particular food, we can make sure we manage it in the meal plan. But for all of this, it has to be balanced. I can't just, tell people, yeah, eat eggs, eat this kind of fruit, eat this kind of vegetable. It has to be personalized, because very many times there may be cases where a phosphorus restriction in the initial time is not necessary. We have to emphasize on the importance of being watchful of phosphorus in the beginning itself, but many times they may not need it to start off with. So as Dr. Girish said, for us, malnutrition is a huge problem, because in Indian diets, even if somebody tells us that they are a non-vegetarian, it does not mean that their 90% of their food consumption is non-vegetarian. It will only be a small supplement to a vegetarian diet. So healthy swaps, I would like to say a few things, which would be avoid the yolk, have just the egg whites. Instead of having processed cheese, have homemade paneer. Instead of having a dark colored cola or a soda, have homemade lemonade. Now, again, I want people to be watchful that these are swaps. I'm not saying that these can be included on a daily basis for everybody on dialysis. Again, planning and therefore putting into action a meal plan is very necessary. Does
Thanks,
that answer
doctor.
your
Yes,
question?
yes, absolutely. I mean, even if patients were looking for a miracle reversible cure, you gave them more information and relevant information that is required, actually. So thanks, doctor. So I think I'll take one more question for Dr. Girish, because we are a little tight on time. So, Dr. Girish, what are the initial signs of bone damage and dialysis patient that they should not, they simply must not ignore? So, initial signs of bone damage that they should not ignore.
Yeah. I mean, there are no particular signs as such to start with, which is where I think monitoring phosphate levels regularly from CKD stage 3 plays an important role. Unfortunately, it may be after the first fracture that these things can come to light in some patients. So, if you ask me about the sign, probably a trivial injury causing fracture, and that needs definitely investigation. Let's say somebody is not monitored the phosphate levels for whatever reason, and then they subsequently end up on dialysis, and then they sustain a very fracture to a very trivial injury. That should trigger the alarm saying that, look, my bone is not healthy, and get those tests, relevant tests, which basically are blood tests, calcium, phosphorus, and PTH. In some cases they do DEXA scan to assess the bone mineral density, to look at the bone health. So combining all these things, and if there is a fracture, then these sort of things can put together and tell your bone is not healthy, and then they have to take adequate precautions to strengthen their bones.
Okay. Thanks, Dr. Girish.
Okay.
And on this note, I thank you. I thank you from the bottom of my heart, Dr. Girish and Dr. Swati, to be part of our virtual conference. And may you continue to engage with us at Kidney Warriors Foundation, so that our patients may gain knowledge from your inputs and insights. Thank you again. And over to you, Marianne, for the next session.
Thank you.
Thank you.